As I said, I'm actually a child and family therapist at the Virginia Treatment Center for Children. We're located down near MCV, about a block and a half from the main hospital. It's an inpatient psychiatric hospital for children and adolescents. It's for crisis stabilization. We also have an outpatient program for children and adolescents, as well as what we call a co-occurring program, which is kids who have dual diagnosis of mental illness and substance abuse. We do medication management with our psychiatrists. We have psychologists, social workers, licensed clinical social workers, there. We usually get kids who obviously are suicidal. We also get kids that are homicidal, aggressive, psychotic, out of control, self-harming, those kinds of things. Usually they stay with us for about up to a week, give or take, on the inpatient program. We really kind of focus on individual therapy pretty much almost every day, family therapy, really trying to focus on coping skills, and I'll get to that in a minute. Like I said, we serve kids up to 17 years old. I'm also kind of faculty at VCU, so I kind of do a lot of different things, but one part of what I do is some teaching in the Department of Psychiatry. And what I find is that even these doctors in training know their book stuff, but when it comes to really assessing kids, you got to look beyond the books. Some of the research efforts that are going on at VCU on kids obviously touch on suicidality in that they deal with depression, obviously, anxiety, again, psychosis, those kind of things. Now, we see a lot of different diagnoses, and of course one of the risks for kids in suicide is having a mental illness. And a lot of the signs and symptoms are the same as what you get with adults. A history of a suicide attempt, depression, other mental illnesses, situational crises, history of abuse, those kinds of things. What I think is really important is that what we do a lot of at the treatment center is a lot of assessment. I teach my students all the time, you have to look at mood versus behavior. So I say that because as regular lay people, they see a kid doing certain behaviors and they think, oh, they're just being a kid. But what I see is, well, obviously when they come to the hospital, they're there for a major reason. But what looks like in kids is aggressive, or looks like what's wrong with them, they're banging their head on the wall, and they're just angry, is not always what it seems. Many times the kids are having other symptoms related to other diagnoses, like I said, depression, which in children looks like anger, rage, irritability. It might be post-traumatic stress disorder where they're having flashbacks or something like that, and they're trying to get them out of their head. Like I said, psychosis. So with kids, you're really looking for that behavior. I'd say behavior has meaning. So the most important thing, though, when you're looking at kids is not to minimize what you're seeing. And a lot of parents will say, gosh, all of a sudden they're just really angry and hitting their sister all the time. And that's just not like him. So as someone said earlier, you're looking for changes in behavior, and of course some of those other signs and symptoms like changes in appetite, changes in their sleep pattern, aggression, more aggression than kind of what was normal for them, or irritability, any changes that are observed that are out of character. And I think the most important thing, a take-home, is to not ignore those warning signs that it's not always boys will be boys, and sibling rivalry. Well, sibling rivalry is one thing, but when they're pulling each other's hair and slamming them against the wall, it should kind of go on your radar that something's amiss. Like I said, risk factors, of course, of mental illness, family stress and dysfunction, situational crises like death or divorce. We've had a divorce run lately, it seems. Not to say all kids are going to be suicidal if they're divorced. I usually find that For a lot of kids, there's either a predisposition of a mood disorder or mental illness with life stressors, and they kind of come together, and perhaps the kid is really struggling. Suicide, by the way, is the third leading cause of death of kids between the ages of like 10 and 19, which I found kind of interesting. I think, like someone said before, it's interesting to note that kids will, like adults, directly or indirectly talk about suicide. There are some kids that don't, of course, but some will have mentioned it, like, I'm going to kill you because I'm so mad. We get a lot of those kind of kids, and the parents say, oh, he always says that when he's mad. And what we tell them is, you know, they may be incredibly angry, but that shouldn't even be on the radar when you're 9 years old. Now, like I said, you see more irritability and anger with kids, which can be depression. And what's important is that kids don't have the language skills to tell you that something's really wrong with them, and yet they know that something's not right. Most of the kids that are even out of control and they seem like they're mean and bullies, and they come in, you peel that back and you see that they really know that something is not right with them. They know that they don't feel normal. I think it's important to just listen to those comments. As I said before, I'd rather die than whatever, you know, I'm gonna kill him if he comes in my room. That's just kind of extreme. There's extreme statements. The other thing that research shows is that persons in general and kids, is what we worry about is impulsivity. In other words, people will have a lot of emotion, and when they become suicidal, they think they want to die, and they may do something and they regret it later, but they were impulsive about it and they can really hurt themselves. And so some suicides are completed because the person hurt themselves and they couldn't go back, and they didn't really mean to go through with it. There's also a phenomenon now, if you know, kids in cutting behavior. This has been an important thing. People think, oh, they're cutting themselves, they're suicidal, and that's not always the case. However, to me, is a very large warning sign in that if a kid is cutting, they may say, oh, I just cut when I'm angry, or I'm cut when I'm bored, or I'm cut different reasons. But to me, if they're in that much emotional pain, it certainly begs to pay attention to. The other thing I tell a lot of parents, PCPs are great. A lot of parents take their children to their physicians, and they do a lot of good work in making referrals. But I would suggest that if you know a child that you think something is really possibly going on, take them to a psychiatrist and get a formal evaluation versus a PCP. The other thing I hear a lot is that kids do this for attention. I have not really found that very often, I can tell you. That's a whole other day, but I just don't see that. There are some kids that have a history of hurting themselves a lot, and that's part of their personality style. But underneath that, when you peel that back, you get depression and anxiety usually, or some other mental illness. What we're trying to do too is we're really trying to include more family involvement. It's important for kids to be connected, and I think with all technology now, they're not quite as connected as they used to be. So when we have a kid come in, we're always making referrals for community activities and things like that. The other thing is that the schools, I always make sure that the kid has a connection at the school of somewhere they can go if they are having a hard time. And I think schools need to be more aware of the warning signs as well, because kids spend most of their day at school. So if the schools can be more educated, they may see things that they think a kid's just a bad kid, and really the kid is really struggling. I guess that's about it. I thank you for having me, and thanks.